Assalamu alaikum. Our seminar today is about iron deficiency anemia, supervised by Dr. Zainab Ahmed, presented by Sidra, Qahtan, Fatihy, Rafal, Akram, Qasim, Reem, Moufaq, Mohammad. This is first part are presented by Sidra, Qahtan. How does the body absorb iron? Our diet contains two forms of iron. The first is heme iron or iron bound to hemoglobins or myoglobins that comes from animal products like meat. Heme is in the ferrous or Fe2 plus state. The other forms in non-heme irons which free iron molecules in the ferric or Fe3 plus state. Non-heme iron comes from plant-based food like spinach. Now, when the food is broken down in the stomach, iron is released. Heme iron is absorbed directly in the duodenum cells where it's broken down to release ferrous molecules. Non-heme iron, however, need to be reduced to heme iron first, so the stomach hyaluronic acid activates a group of enzymes in the duodenum cells collectively called ferric reductase, which live up to their name by reducing non-heme iron ferrous molecules. Ferrous molecules that then bind to proteins in the duodenum cell called ferritin, which temporarily stores the iron, and when is needed in the body, some ferrous molecules are released from ferritin and transported into blood, where the enzymes have faced in convert them back to ferric state. Ferric molecules then bind to ions and transport to protein called transferrins that carries ions to various target tissue and release them. Their ferric enters to various tissue cell where more ferritins that can store them for future use. Now, the factor affecting iron absorptions. First, body need of iron, stomach pH, food content, ascorbate vitamin C, lactate, and succinate increase iron absorptions. On the otherwise, oxalate, phthalate, and phosphate decrease iron absorptions. Hypoxia, anemia, the most important factors and considers the masters of iron regulations. Hepcidin. Hepcidin has central role in the regulations of metabolism and absorption. A product of hepcidin antimicrobial peptide gene is the small peptide with several isoforms. It's predominantly expressed in the liver. It regulates iron hemostasis by binding to cell surface ferroportin, causing its tyrosine phosphorylations, internalizations, dequinations, and degradations in lysosome. It therefore acts to inhibit iron absorptions, iron release from macrophages, and iron transport across to the placenta. Body iron regulations by hepcidin. First, body iron decreases lower hepcidin synthase in the liver. Hepcidin deficiency target the duodenum and spleen. Duodenal absorptions of iron increase. Splenic iron is released into circulations. Iron concentrations in the plasma are increased, that leading to restorations of iron balance. Now, what is the iron deficiency anemia? It's a common form of nutritional disorders. Iron deficiency results in anemia as iron is necessary to make hemoglobin K molecules in red blood cells and responsible for transport of oxygen. The prevalence of iron deficiency anemia spans all ages and race. Now my colleague Reem will continue.
This is the second part presented by Reem Moufaq. Clinical data and symptoms of iron deficiency anemia. Initially, iron deficiency anemia can be so mild, that it goes unnoticed, and iron deficiency anemia tends to develop slowly. Therefore, the body has time to adapt and the disease often goes unrecognized for some time, and the patient may be presented with some symptoms like extreme fatigue and weakness with headache, pale skin, cold hands and feet, chest pain with shortening of the breath, and may be accompanied by fast heartbeat. These symptoms caused by low levels of hemoglobin that the body will not be able to transport oxygen to the muscles and tissues effectively. But as the body becomes more deficient in iron and anemia worsens, the signs and symptoms intensify and tissue changes will develop. This will include inflammation, swelling, and soreness of the tongue and mouth, stomatitis, with anecular cracks of the lips, cholosis, brittle and spoon-shaped fingernails, conychia, pharyngeal waves that will lead to dysphagia. For children and infants with iron deficiency anemia, they will be presented with poor appetite, repeated infections, behavioral problems, and maybe with impairment of mental development that they fail to grow at the expected rates. And thank you.
This is the last part of our seminar is presented by Rafal Akram, and I will talk about the diagnosis of iron deficiency anemia. About the diagnosis, in most cases, we depend on clinical data, typical red blood cell morphology from the blood film, and the reduced transferrin saturation from the serum parameters. In more complicated cases, we use the most accurate test like serum ferritin, bone marrow iron assessment. About the laboratory finding, first the blood film shows microcytic hypochromic RBC. Microcytic means the mean corpuscular volume is reduced and it is usually below 80 femtoliter. Hypochromic means mean corpuscular hemoglobin concentration or MCHC is reduced, and this can be noted in the blood film as microcytic small RBC and hypochromic reduced hemoglobin as abnormal expansion of the central pallor. Anisocytosis means variation in the size between the RBC cell in the film, and poikilocytosis, abnormal RBC irregular shape like the pencil cell. Other findings, the platelet count, white BC are usually normal, though some hypersegmented neutrophil can be noted. About the bone marrow is usually hypercellular to compensate the loss of the RBC. We can note also development of erythroblasts. There is normoplastic erythroid hyperplasia. Normoplasts show shaggy outlines, vacuolated cytoplasm, and pycnotic nuclei. Pycnotic nucleus mean condensation of the chromatin in the nucleus. The important point in the bone marrow is the depletion of the iron from the stores, and this is a differentiation point between the iron deficiency anemia and the thalassemia. In the iron deficiency anemia, there is a depletion of the iron from the stores, and we can know that by use pearl personal blue stain, while in the thalassemia there is no depletion of the iron from the stores. About the serum parameters, we can note the serum ferritin is reduced, the serum iron is low, the transferrin raised, transferrin saturation is reduced, and this is the important point. Transferrin saturation means the transferrin transfer the iron to the site of the action. In the microcytic hypochromic anemia, it is usually reduced. Here's the table of the serum parameters of the iron deficiency anemia. Shows serum ferritin reduced, serum iron reduced, transferrin increased, serum transferrin saturation is reduced, mean corpuscular volume is usually reduced. It is usually below 80 femtoliter, and other cytokine levels are normal. We can do other investigations like history of blood loss or malabsorption or malnutrition or other underlying disease. We can do test for parasites. Some parasites like hookworms lead to loss of blood from the mucosa of the intestine and lead to the iron deficiency anemia. And also we can do the urine haemosidrin. Here is an important diagram to evaluation of microcytic hypochromic anemia. How we can differentiate between the iron deficiency anemia and the thalassemia. This is an important point because both of them are microcytic hypochromic anemia and the mean corpuscular volume or MCV below 80 femtoliter. We can do the serum ferritin. As we said, it is an accurate test. If it is low, it is iron deficiency anemia. If it is normal, we can do hemoglobin electrophoresis. If it is abnormal, it is thalassemia, and if it is normal, it is anemia of a chronic disease, sideroblastic anemia. Here is the differences between the thalassemia and the iron deficiency anemia. Shows the thalassemia, as we know, it is a hereditary disease, while the iron deficiency anemia, as we said, it is not hereditary. It is acquired from underlying disease or malnutrition, malabsorption, blood loss, or parasitic or other things. Important thing in iron deficiency anemia, the iron is absent from bone marrow, while in the thalassemia it is present in the bone marrow. In the iron deficiency anemia, the microcytosis, as we said, mild or absent, while it is usually very severe in the thalassemia. The basophilic stippling of the red blood cell is frequently in the thalassemia, while it is less frequent in the iron deficiency anemia. There is an important point about the iron therapy. There is a response to the iron therapy in the iron deficiency anemia, while in the thalassemia there is no response and we need the blood transfusion. There is other important point about the mean corpuscular hemoglobin concentration or MCHC in the iron deficiency anemia is usually reduced, while in the thalassemia it is normal or increased. And thank you.